Hello, hello, my beautiful people. I hope you guys have a beautiful, lovely day today. The weather is beautiful. And before we start, I want to talk to you guys about responding to thoughts, right? Which is also called cognitions. Now, thoughts are basically physiological events that manifest as words, sentences, images, ideas, and memories in the mind, right? Every day, moment by moment, we experience thoughts that arise automatically and outside of our control, about all kinds of things. These, what we call automatic thoughts, are natural reactions to internal and external triggers. For example, other thoughts, emotions, bodily sensations, urges, behaviors, and events are consciously accessible to our mind. In addition, we possess attitudes and beliefs that we have built up over time as a result of our early life and past experiences. Okay? Now, basically, I'm just reading from my little pocket coach little book called The Calm Coach. Okay? And we may not be conscious of this, but they affect how we think, feel, and act. Now, thinking enables us to survive. It comprehends the world, develop a sense of self, forge and maintain relationships with others. It allows us to plan, remember, problem solve, engage in activities, reflect, imagine, strive, and create, and also thrive, right? So it's no wonder we tend to listen to our thoughts, believe them, and react to them. A process which is what we call fusion. Fusion is adaptive when the thoughts enable us to live well and cope with life. However, when our thoughts are influenced by stress, fear, and old beliefs that may be unkind, unconstructive, or untrue, fusing with them can cause us more stress and problems, right? Therefore, difficult thoughts are a natural part of our human experience, and suffering is very common. Fortunately, we have the capacity to think about our thinking, right? And this process is actually what we call metacognitive awareness, right? Almost like a mindfulness practice. Now, with this kind of reflection, we can learn to observe our difficult thoughts, unhook ourselves from their content, and change our relationship with them, which is a process called diffusion, so that we don't inadvertently cause ourselves unnecessary pain and suffering. And this can help us feel a greater sense of calm and control during turbulent times, especially during times of stress, right? So, on that note, guys, that was just a very quick um uh I just wanted to share some effective solutions in regards with coping with our stress when we're under duress, and coping with rumination, which is basically thinking, overthinking, right? And everybody overthinks. Therefore, you know a mindfulness practice, or what we call diffusion, diffusing and disconnecting from our monkey brain, our thinking brain, is essential. Now, how does that correlate with our NCLEX review? So, I want you guys to diffuse from any other thoughts that you might have had prior to this review, and let's focus on a few respiratory issues and diseases that you will most likely encounter in your exam. And that would be COPD, or chronic obstructive pulmonary disease, and ARDS, or acute respiratory distress syndrome, right? With chronic obstructive pulmonary disease or chronic or COPD, uh, it basically encompasses, um, a few chronic respiratory disorders, right? Which includes chronic bronchitis, emphysema, and asthma, right? Now, what occurs is that basically there's an abnormal gas exchange of ventilation in the process of perfusion, right? And this causes an impaired gas diffusion within the pulmonary capillaries in the patient with COPD. So when we do assess them, we would see some pursed lip breathing, the use of accessory muscles, right? And barrel, what we call a barrel chest, which is basically when the AP diameter is 1 to 1, right? The normal AP diameter is 1 to 2. So AP basically means anterior, posterior, transverse. Basically the anatomy of the lung, right? And the diameter is basically 1 to 1 instead of the normal, which is 1 to 2. Now, when we're looking at a patient with COPD, a major complication would usually be hypoxemia, right? And also hypercapnia. Now, we're talking about hypoxemia. We're looking at the 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 partial pressure, right, of oxygen or PaO2 that is less than 55 millimeters of mercury, right? And the O2 or oxygen saturation would be less than 85% usually with patients with COPD. Okay? Therefore, in with COPD patients, they have what we call CO2 narcosis, right? Now, in normal patients, the carbon dioxide in the blood increases stimulation to breathe. However, in patients with COPD, when the partial pressure of CO2 is high, right? Let's say over 60 to 70 millimeters of mercury for a long time, the brain then becomes sensitized to the decrease of partial carbon dioxide. Hence, the brain does not respond to uh, carbon dioxide to stimulate breathing. Rather, the brain responds to um, a decrease of oxygen, partial pressure of oxygen, which would be below 60 millimeters of mercury to stimulate breathing. So we conclude that if PO2 stimulates the brain to breathe in COPD patients, oxygen therapy can basically remove their brain stimulus to breathe, right? So basically, the thing that we have to remember is that we don't administer high liters of oxygen, right, for patients with COPD, whose respiratory stimulus depends on a low oxygenation, right? So therefore, we don't give more than 2 liters of oxygen since the respiratory center has adjusted to high levels of carbon dioxide, right? Now, a big thing with COPD treatment that you will most likely encounter in your exam would include your bronchodilators, your B2 agonist, which is Provento, right? Those are some of the common meds that you will encounter. Your xanthines, right, such as aminophylline. Your anticholinergics, such as Atrovent. Your anti-inflammatory, usually corticosteroids. Your mucolytics, such as SSKI, and your antibiotics, okay?